I'd like to do this morning is give you a recent update on what some of the things I think are truly exciting going on, primarily in sepsis, because I think this is a major area that needs our attention, and the field is moving very fast in this. And my first slide here is trying to sum up what I believe to be, the most important aspect of acute kidney injury, whether it's ischemia or sepsis, and that's this interaction between the different cell types that occurs within the tubule, the endothelium, and the interstitium of the kidney. Most of us study one cell type, and we try and relate all of AKI to that cell type, when we now know that this is really an orchestra of events, both under normal physiologic conditions and then following a perturbation, such as we have with ischemic or septic injury. And one can see the different players in here, and some recent work out of this institution, not mine, but Pierre Dager and his laboratory, I'm going to spend the latter half of this presentation talking about, because I think it explains some of the features that we have not explained before, especially in human AKI. So if you remember this one slide and the interaction of the different cell types, the endothelium, I'm going to ask Noel, can you see my arrow if I move it around on here? Can you see this arrow moving?
Yes, Bruce, we can.
Perfect. Okay. So what do we know clinically? Well, this was a very nice paper out of the Hodgkin group, in which they looked at a rapid autopsy of the heart and kidney following sepsis in patients that were going to be taken off the ventilator and die. And what they showed was that the autopsy findings revealed a patchy proximal tubular injury with apoptosis and necrosis. The corticomedullary junction was injured more than the cortex. There was a patchy microvascular obstruction, so we're emphasizing here patchy or focal. And they could document mitochondrial and lysosomal alterations. And if you just look at the percent of injured tubules here, figure D, you can see a lot of variation in the septic patients, but obviously an increase up to about 8% or so, 7 to 8%. So not all the tubules were injured by any extent and couldn't explain the extent of the acute kidney injury. If you look at KIM1 labeling in the cortex in figure F, or KIM1 labeling in the corticomedullary region, figure G, you can see that in the cortex it's patchy, in the corticomedullary region it is more uniform. And if you look at the percentage of injured tubules, you'll see we're not talking 7%, we're talking 25 or greater in the cortex. And if you look at the corticomedullary junction, we're, in the 35% range. So greater injury, less focal, but still focal and patchy. If you try and understand acute kidney injury from ischemia or sepsis, I like to divide it into three phases. And what you see at the top in panel A is a biopsy from a human taken for glomerular reasons, and you see a relatively normal-looking cortical proximal tubule region. And then right next to it is a human biopsy that was provided to me by nephropath, showing tremendous interstitial involvement, lots of cells in the interstitium, and by the interstitium I mean both the microvasculature here, the peritubular microvasculature, and also the non-vascular area of the interstitium. You can see if you look at closely at this, it's going to be difficult to perfuse this. And when one looks at then the phases, the initial is a cellular injury, followed by an inflammatory phase, followed by a fibrotic phase. And there's a lot of work going on in a number of laboratories about the maladaptive phase or the fibrotic phase following injury, which I believe will be very important in the future. The other thing to keep in mind is that the process activation, and so I'm calling these processes, is directly related to the extent of injury. So anything we do to limit the extent of injury will limit the process activation, will limit the initial injury and the subsequent follow-on fibrosis and scarring that occurs to the kidney. And we also know that we're not dealing with just acute kidney injury now. We're dealing with a spectrum of acute and chronic kidney injury where chronic kidney disease makes you more prone to developing acute kidney injury. And with each episode of acute kidney injury, you march down this sawtooth pattern toward eventually going on dialysis. And so we have to think about this when we're trying to understand the pathophysiology and what we're trying to do to patients. Now, a number of years ago, we drew this cartoon where we talked about the physiologic and clinical phases of acute kidney injury, and we talked about patients that were at risk at a high percentage of developing acute kidney injury. We talked about injury as being a relatively rapid phenomenon in which you drop your GFR precipitously. This certainly happens in some cases, but in sepsis, this may be a much more gradual diminution in function, but it's just not picked up because we do not have the sensitivity in our serum creatinine to pick it up rapidly. Now, with the new biomarkers coming in line, I think we will start to understand much more of this early phase. Then there's what we call an extension phase, which is a microvascular injury phase in which you have the inflammatory component leading to more and more inflammation, loss of microvasculature, leading to a worsening GFR. The maintenance phase in which the cells put themselves back together, and then the recovery phase in which you repolarize and blood flow returns and urine output returns. Therapeutically, industry thinks about this as either limiting the severity of injury with a prophylactic type of treatment, minimizing the extension phase, the microvascular phase, or coming in for secondary therapy and trying to hasten the recovery phase. And this has formed the basis for different classes of molecules moving forward. So let's now move to sepsis and talk about the endothelium. And you all remember that the kidney is a unique organ in that its oxygenation goes from normal at the cortex to very, very low in the medullary region. That there is a region, the outer stripe, or what I call the corticomedullary region, that it has very minimal arterial blood flow and primarily capillaries from the venous side of the tree, circulatory tree, and such that the two things here. The oxygenation is down and also the expression of cell adhesion molecules is up, both of which makes this a very vulnerable area, not only to ischemic injury, but more so to reflow and to loss of microvasculature over time. Now, when we think about the microvasculature within the kidney, it's very important to remember that we have both series and parallel resistors. So the blood enters the glomerulus. This is not one long spaghetti, as they would think about in Italy, but this is an interconnection of capillaries all throughout this glomerulus, such that if one is occluded, the other can resume flow by moving in a different direction. So there's parallel movement of the microvasculature here. The same is true in the peritubular capillaries. You can occlude one area and have delivery to that tubule on the other aspects of it through this parallel vascular flow, and obviously the same is true in the vasa recta. So this serves the kidney well in that a microinfarct within one aspect of the peritubular capillary can be compensated in large part, not totally, but by flow around it from this parallel nature. I can't show you any videos because of Skype, but I will remind you that under normal conditions there is very good peritubular capillary flow, and you can see it here around the tubules very nicely on the left hand. And on the right, and this is in the corticomedullary junction, following ischemic injury in this case, but I could show you the same for septic injury, You have vasoconstriction of the peritubular capillaries. You have rouleau formation. You have white cell adhesion. Then a rouleau backs up against it, forming basically a microvascular plug. Here you have plasma streaming around that plug such that you have no cellular components but just a lot of plasma, and we understand that that doesn't deliver oxygen. And so you have a very ischemic area. We know from David Basil's work over the last probably 15 years and a nice series of 10 to 15 articles that this corticomedullary region is then prone to this patchy, okay, and this is cortex here, but this patchy involvement of injury following AKI, and that angiotensin II makes it worse, and that this leads to fibrosis and microvascular dropout. So David's plotted here on the right-hand side the renal interstitial volume, and you can see that the interstitial volume increases, the fibrosis increases, and this is done again in a patchy model. Now, Tim Sutton and I showed a number of years ago that the microvascular flow to a given area correlated very nicely with the injury to the proximal tubules in that area. If there was normal flow, the proximal tubules looked fine. If there was abnormal flow, there was tremendous damage of the proximal tubules. David's work would say that abnormal flow leads to microvascular dropout, fibrosis, and worsening renal function. We've also shown that the glomerulus is involved in sepsis. Here on the left-hand side, you can see normal flow through a glomerulus cut across the upper portion of the tuft. And here you can see the middle of the glomerulus where you have rouleau formation, you have white cell adhesion, you have large platelets that you all know we see in sepsis, and you have this microvascular streaming because of a occluded capillary network within the glomerulus. So the glomerulus is not immune to what goes on during sepsis. In a recent review in KI, I think just this month, Rob Starr's group tried to point out the potential importance of microparticles. They emphasize here the endothelial cell and its role in AKI and sepsis in particular, and fully acknowledging that all cells can release these microparticles, and they've been shown now to play a role in microvascular injury in a paracrine type fashion. They've been shown to be involved in inflammation, thrombosis, DIC, and also immunosuppression. And these are released by any endothelial cell. The regulation of that is really not understood. This is a brand new area. And following release, they expose phosphatidylserine and tissue factor, which play a major role in the coagulative aspects that are ongoing. And here's just a nice summary slide looking at endothelial cell-released microparticles on the left and leukocyte-released microparticles on the right, and some of the different things that they do within the vasculature, causing increased cytokine production, adhesion molecule exposure, tissue factor exposure, coagulation, thrombin generation, and you can see the same and more is true for white cells. So this is going to be an area of active research and maybe something that can be influenced in the future. Now, we also know there are mitochondrial alterations that occur to the epithelial cells, and we're going to move on to the epithelial cells. And this was work by Hall using two-photon microscopy to look at NADH following ischemic injury, mostly in the cortex here of a rat. They used then a mitochondrial marker to look at the potential across the mitochondria, which is obviously very high under physiologic conditions in E, and reduced markedly in F following application of a clamp around the renal artery. And you can see here the fluorescence falling off very rapidly over time. Within about 7 minutes, it goes from normal to a very low level where it's then stable. They also showed, which was known previously from in vitro studies, that the proximal tubule was the most sensitive to this injury, the distal tubule second most, and the cortical collecting duct third most. And you can see here, if you put in the proximal tubule, it would be very down to here, distal tubule, cortical collecting duct. So tubule segments vary in their sensitivity to ischemic injury. Now recently, and I hope Dr. Gomez is in the audience, because his group and several others have championed the idea that DAMPs and PAMPs are very much involved in what's going on with ischemic injury. And you can see here the filtration of DAMPs and PAMPs, subsequently mediating S1 uptake and activation. So the signaling is very important. It occurs in the S1, and this is Pierre Dager's work. And subsequently to this, there is paracrine signaling down to S2, S3, which induces an oxidative reaction and peroxisomal reaction within those cells. Now, Pierre has shown that the uptake of these DAMPs and PAMPs is in part mediated or largely mediated by TLR4, and the expression of TLR4 goes up following injury, and it migrates to the apical membrane in these S1 proximal tubular cells. So we're seeing now how one proximal tubular cell type influences other proximal tubular cell type based on materials released from yet other cells in the body. So I'm going to show you one nice study that just came out this last week in print form in JASN, and I'm going to talk to you about LPS as a mediator of septic injury and what's going on in the kidney in response to LPS, and how we might be able to use preconditioning to prepare patients for this to come. So this is work, again, out of Dager's lab, and Hato was a fellow and is now a faculty member here continuing on with this work. And what we're going to look at here is the role of TLR4 in LPS tubular injury, and you can see a sham-treated, non-infused, non-LPS-infused cortical aspect here with two-photon microscopy using this marker as a marker of oxidative stress. When you give 5 milligrams of LPS to a wild-type mouse, you get tremendous oxidative stress. If you give it to a TLR4 deficient knockout mice, you see no oxidative stress. And if you give white cells, bone marrow cells, from a TLR4 knockout mouse to a wild type, so it has it in the kidney but not in the white cells, you see oxidative stress. Okay? So it's the TLR4 in the proximal tubules, primarily in S1, that mediates this oxidative stress within the kidney, not the white cell component following an LPS injection. They went on to look then at preconditioning, and they used two modes of preconditioning, one in which they gave a very small dose of endotoxin 24 hours prior to the large dose, and one in which they gave a moderate dose of endotoxin 3 days prior to the large dose. And if you look at C here, you can see again the oxidative stress that occurs in wild-type mice following injection of 5 milligrams of LPS. However, if you either pre-treated 1 day or 3 days ahead with differing doses, you could see that the administration of 5 milligrams had no oxidative stress potential whatsoever in those mice. And if they looked at LPS labeled with Texas red uptake, you can see that the uptake into the S1 cells was not blocked by this preconditioning. In fact, it was, if anything, increased following preconditioning compared to non-preconditioned mice. And that you can see what they'd shown previously, that in TLR4 knockout mice, there is virtually no uptake of the LPS and thus no response. So the preconditioning increased uptake of LPS, but inhibited the oxidative stress. Now they went on to show that this preconditioning minimized peroxisomal injury by, in fixed tissue here, looking at catalase. So sham physiologic animals given LPS 5 milligrams, you can see loss of catalase. And preconditioned animals, mice, you can see the catalase remains very functional, and in the peroxisome. They went on and did the same thing with another peroxisomal marker, just showing that this oxidative burst is, at least in part, from the peroxisome, and that the preconditioning protected that. They went on further to look at different models of injury, and here they looked at what was the effect on renal function of preconditioned animals, and you can see that they lost very little renal function in preconditioning. You can see that KIM-1 was not elevated in the urine of those animals, and you can see NGAL went up a little, but nothing compared to the non-preconditioned animals. They then asked if this worked in other models of sepsis in which they injected E. coli, and you can see that preconditioning with LPS protected against KIM-1 activation in E. coli. It protected against NGAL activation. And they then went on to a CLP model in which they showed that preconditioning with LPS also protected against the sepsis induced by fecal ligation and puncture. So it wasn't just LPS for itself. It actually protected against infection with either injected E. coli or the CLP. They went on to show that the hematopoietic TLR4 was essential for LPS preconditioning, and if they knocked out the hematopoietic TLR4 using bone marrow chimeras, that their preconditioning did not work, that they got the oxidative burst when they exposed to the 5 milligrams, implying that, again, the hematopoietic cells play a role in sensing this preconditioning. And they went on and showed that, in particular, a macrophage CD14, which is known to be a co-receptor of TLR4, was required for this preconditioning to the LPS, in which if they used CD14 knockout bone marrow cells in wild-type animals, they got their oxidative burst. That was similar to what they found in non-preconditioned animals. So that without this macrophage type, they could not precondition their animals. They went on to look at other things preconditioning might be doing to the kidney that would minimize the injury to these animals, and what they found was that it increased the amount of both HO1 and SIRT1. And it did so very, very nicely, especially in these preconditioned animals. You can see here the HO1 is not only at the same level, it is upregulated, and the same was true for SIRT1. They went on to show the same thing for iron proteins, but I'm not going to take the time to show you that. So preconditioning, macrophage dependence, and multiple cellular processes which are protective upregulated. They were very interested in the macrophages further, and so they went on to look at what this did within the kidney. And interestingly, they showed that not only did the number of macrophage increase following preconditioning, but they tracked those macrophages using a special tracking equipment you can do with the 2-photon. And these red lines then show an individual macrophage moving around the kidney, and here moving around a particular tubule. And you can see there's markedly more macrophage movement in the preconditioned animal than there was in the non-preconditioned animal. And you can see the accumulation of these macrophages around tubules and glomeruli, but primarily around tubules and especially the S1 in preconditioned animals, not so in unpreconditioned. And we all know that at least part of the macrophage family is destructive, and part of the macrophage, the M2s, are, I won't call them protective, but they're certainly not destructive. And they went on to show that the percentage of the M2 macrophages found within the kidney with preconditioning went up in these mice. And you can see that here. Now, it wasn't a huge rise, but it was about a 30% rise. And they did a heat map to look at these different cytokines and chemokines, and you can see that this is just cortical homogeneous. You can see the remarkable reduction with preconditioning. So I think I'm going to end here with this slide and then the next one. But when we think about ischemic and septic AKI, we need to think about an orchestra in which our job, I think, is to stop the processes early on so that there's not the usual cascade and amplification that occurs. This preconditioning, I know, hopefully John Kellum's in the crowd. He recently had a paper out on preconditioning using forearm maneuvers in a large clinical study, and it's really something that we should be thinking about in our patients. So when you think about ischemic injury, don't think about a particular cell type. Think about the interactions between cells, and if there's a way to stop this crosstalk between cells, that might be a very effective way in minimizing the overall injury. So my summary slide is there are many pieces, some known, some linked, and this is actually this puzzle turned upside down and spilled on the floor, and it's our job to try and put these together by recognizing how they interact with each other so that we can get to this level of understanding and treat our patients as a unique puzzle, each one, and develop tools to individualize therapy, realizing that each patient is unique and each injury is unique.